Okay, so the next
Okay.
session we have is by Professor Madya Dr. Ahmad Khaldun bin Ismail, who is Professor Madya and Pakar Perunding Kecemasan from Hospital Chancellor Tunku Muhriz University Kebangsaan Malaysia. So, Doctor, you can start when you're ready. Thank you.
Okay, thank you so much for the short introduction. So there will be maybe 2 or 3 parts of this session. I was made to understand that this will be what we call a workshop. So I will actually try to include some introduction to the topic, and then we will have a bit of a discussion. On top of that, I will probably just run through with you the quick guideline that we have been using in Malaysia for some time. And if we have the time, we probably have some fun later for a short Kahoot quiz. And all participants are encouraged to join with your mobile phone. I hope your connection will be good, okay, when we have the Kahoot quiz later. Okay, so if you have any questions, please submit your question to our moderator, and the moderator will then ask the question to me for the discussion later on. Okay. All right. So let us begin. My title is Snake-Related Injuries: Optimizing Clinical Management. There's a quick declaration. I have no conflict of interest for this session. So just a bit of agenda or content of my talk. We're talking a bit about what is safety and health-seeking behavior. I will talk a bit about the first aid and current practices in managing snake bites in Malaysia, or snake-related injuries, and what some of the recommendations that we put forward for the clinical practitioners, professionals, and also for pharmacists in terms of the antidotes that we use, or antivenoms. Okay, so let's begin. So a small reflection on the terms. What is toxins? What is poison? What is venom? So toxins is basically a natural product that we use from organic or living organisms. So these are naturally produced to defend themselves or to obtain their food. Okay, so whether we term something that can cause harm to us a poison or venom will depend on how it get introduced into our body. So if we ingest a substance and we get sick, if we apply something on the skin, absorbed, and we get sick, those are categorized as poisonous. But if these substances is injected into our body through the skin, it has to be penetrating the skin, our barrier, then we get sick. That is called venom. Okay, so it's very important to distinguish these two concepts of how harmful material is introduced into our body. So I assume yesterday, most of the time of the discussion is on poison. Okay, and the poison that mostly discussed yesterday was mainly, I think, man-made or synthesized. So those are called toxicants. Okay, but if it is synthesized or made by living organism, those poisons are called toxins. So in Malaysia, it's very clear that we distinguish between what is toxicants, which is toxinology, and what is toxicology, and what is the toxins, which is toxinology. So in toxinology, we can have either poison or we can have venom. Okay, depending on how it's introduced into our body. So that's very clear. Okay, I hope everybody is okay with those terms. So these are, in terms of venom, when we are going to go into snake bites, snakes are living organisms and they have naturally producing toxins And they must actively use this substance for first for predation, how to hunt their food and to immobilize their food, okay, and or for defense, defending themselves against their natural enemy. For your information, humans are not natural enemy to snakes, meaning that the substance that they made, the toxins they made, are basically for thousands and for millennia of years has been driven by the need for them to hunt for their prey, to paralyze their prey, to kill their prey, to eat and to survive, and also for defending themselves. Human came a bit later in terms of evolutionary cycle or evolutionary line. Humans are a bit late, so we are kind of an accident to the whole evolutionary process. We are towards the end. So how the toxins is introduced to humans are not basically uh, for defending themselves or to kill humans for their food. Okay, it's mainly for it's only by accident, and it so happened that we are also organism with spines. We are spinous. I mean, we have a tulang belakang, right? Backbone. So some of the receptors that we have may be also similar to those animals that these snakes eat. Okay, that this snake use the venom for to paralyze or to kill, or the chemical substances, the physiology of the animal. So sometimes the toxins that can paralyze an animal that used for their food or to cause injury to those animal may not affect human. So that's very important to think as well, that not all the poison or not all the venom that this snake produce will cause harm to human. So that's why it's very distinguished between what we do and find in the lab in terms of toxinology studies and what we do with what we find with clinical toxicology. Okay, so that's our role, meaning that we look at how this venom also affects human. It may be different to how it affects birds, how it affects rodents, for example. Okay, so it's important to distinguish, and therefore, uh, what we are suggesting is that we have to distinguish what is the function of this substance or these toxins. So, in summary, basically, if an animal has this toxic substance, we call them a venomous animal. And if they don't have these substances, human out of the equation, okay? If they don't have this substance, we call it non-venomous animal. So if you can see here, an example, a spider. Okay, this is a spider that I had many years ago. I was wondering, is it venomous or not? So what I did was I put this this spider under microscope, and this is what I found. I found that in the naked eye we cannot see. We just saw a fang, but we didn't see anything that can suggest it will deliver venom. So here we can see this is the fang of the spider, and there's an opening at the end of it, at the tip. This is where the venom flows through when it penetrates the skin. So this is definitely a venomous spider, and most of the spiders are actually venomous. The question is whether it can penetrate our skin or not. So kalau mak di situ kulit tebal, maksudnya tak malu lah kan? Uh, then it will not be able to deliver the venom. Okay, so one may not get envenomation. So a spider, for something, an animal like this, it must to cause harm to human. It has to penetrate the skin. Okay, so if it's too small, it may not be able to penetrate, or it maybe just cause a scratch and so on, but it will not cause that much harm. Okay, so what about the effect of the venom to humans? So just now is about the animal. Now is the effect of the venom on humans. So the effect of these toxins to human can be of various hazards level. So it's very important to understand this, because many times we find people use the term so-called, for example, the term highly venomous animal. What does it mean by highly venomous? Or what we call medium, venomous animal. So that has nothing to do with about the animal itself. It's about the effect to human. So an animal can be just either it's venomous or not venomous, but the effect of the venom on human is basically whether it is harmless, whether it can potentially have very minimal harm or danger, for example, just minimal pain, scratch, itchiness, and so on, or it can cause potentially a permanent morbidity. For example, what you call necrosis and causing skin fibrosis, can cause contracture, or even sometimes it can cause amputations and so on. But some can actually cause death directly, not the side effect of the venom or the secondary effect of the venom, but the primary effect of the venom can actually cause direct mortality to human. For example, you stop breathing and you die. Okay, it causes a paralysis. It causes a bleeding. You bleed to death. Okay, or bleeding into the brain. So those are direct effect of the venom. But if it is a bite after a bite, then you get all these problems and you get secondary infection. People can still die, which is from infection or septicemia. So those are secondary, not primary effect of the venom. Okay, that will reflect on how we manage our case as well, our patients. Okay, so most of the time, this venom can cause will present as pain, but some, mind you, some venom do not cause pain. This is another thing to important for professionals, health professionals to understand. Not all snake bite can cause severe pain. Okay, so only certain type of venom can cause cytotoxic effect and cause inflammation. As you know, pain is related to these chemicals and also to this secondary reaction to the mechanical injury. Okay, but some actually cause cytotoxic, definitely will cause severe pain, right? So this is just a summary. Uh, how to tell if a snake is dangerous? Basically, if are you leaving it alone? If no, does it have a chance to escape? If no, are you trying to harm or kill it, grab it, or harass it in any way? If it's a no, then it's not dangerous. But if yes, it is dangerous. Although it's in fact your action is the one that put the snake in danger. Okay, you are the one that caused. You are the one who seek danger. So it's not the fault of the snake at all. Okay, so we are the more dangerous organism compared to the snake actually. However, most of the time, what we find in Malaysia, the cause for the snake bite are incidental, meaning that it's accidental, not incidental, accidental. We did not see, we did not look where we hold, try to grab on something. We did not look at our surrounding, and that's how we get bitten. Okay, so this comes to the topic of what we call um, safety-seeking behavior. So if we can actually be more alert and be more aware of how to mitigate risk of getting bitten by a snake, then we can avoid getting bitten by a snake. So actually, snake bite is a preventive disease. Okay, so and definitely we will promote the idea of prevention is better than cure. And for that, there are certain way of how to mitigate risk, either by positive reaction, negative, reactive, and proactive indicators. So if we wait until something happen and then only we take precaution, that will be too late lah. That is actually reactive or negative indicators. So if we are thinking about this, I hope that's what we are doing now. If we think about all the possible problems that we may face following a snake bite, and therefore we take measures now to prevent something from happening, then that is actually a positive or proactive indicators. Okay, so what we are looking at here is actually transforming our community or our thought process regarding safety culture and the strategy to achieve that. So I just got back from Japan yesterday, actually, very late, early morning yesterday, and that's the reason why I couldn't attend the program with you face to face in Penang because of the time. So in Japan, people are exposed to all kinds of natural disasters, and throughout millennia or thousands of years, they have been able to cope by actually inculcating safety culture. They have a warning system. They have developed very safe roads, building, and so on. Those are how they react to the harm or risks around them. Okay, if you go to Japan, you can see, school children, they do drills and so on. Basically, everybody knows what safety culture is. And as you know, Japan is rather safe because of this. Not just about building infrastructure, but also in the minds and how the people react to certain harm. Okay, so that's very interesting. I hope we will follow. We have this in Malaysia as well one day soon, I hope. Okay, so the other part is on how we react if something already happened. So this is what I call appropriate health seeking behavior. Just now is prevention. Now is actually what do we do to mitigate so that it doesn't make it even worse. So for this, we have to look at how the system works in our country. Are the people that got injured willing to seek help or treatment from the appropriate source? Or do they go to, for example, BOMO? For your information, we are living in the 21st century. Sorry, is it 21st? 21st century? We are still having Malaysians going to BOMO for snake bite, okay? And there is a famous BOMO in Sungai Petani. He called himself as BOMO Ula Sungai Petani, very close to Penang, okay? So these are the things that, reflect on how good health system in the country. If the health system is good, people will have confidence in the service and they will seek for it. I give you an example. We have a situation in Laos. You know where Laos is? Somewhere near Cambodia, Vietnam, and also Thailand. In the north part, it doesn't have any sea. So Laos has no sea, right? It's not coastal country. And in Laos, still a developing country, underdeveloped country maybe. So the system is very poor in terms of managing snakebite. They didn't have antivenom for snakebite. So people that got bitten and went to hospitals, they never came back to the village, and therefore, people have this impression that if you got bitten by a snake, you go to a hospital, you die. Okay, but over the past few years, through the efforts of some of the doctors that involved with snake bite and venomation, we share resources. We get antivenom to Laos, to these hospitals. And what happened was then people got bitten, went to hospital. They were treated well with the antivenom successfully, and they managed to go home alive and probably with minimal injuries after the bite. So what happened? The whole village then, wow, so you still alive, miracle. How can you be still alive when we go to hospital? So people tend to get a bit more confident in the service, and they start coming to hospital. And now the problem now we don't have enough antivenom to serve the people coming for snake bite in the hospital in Laos. So I will explain later what we do with this regards of inadequate antivenoms. Okay, so again, what I'm trying to say is in Malaysia we are very lucky. I think our Ministry of Health is very receptive to the needs of envenomation, and we have the appropriate antivenom for our country. In the past, we had problems, okay, where we were stocking the inappropriate antivenoms. So that is another thing when we think about what how to treat, we have to treat with the appropriate antivenoms. Okay, so our healthcare system needs to be beefed up and need to be optimized. Okay, I think that's one of the other reason why we have this workshop today. Okay, so moving on, what about first aid? Okay, so this obviously is not for those already in the hospital. This is actually for the general public. So for snake bite, as for snake related injuries, ways of you can get the injury. One is from the bite itself that can may or may not deliver venom. Some of the bites doesn't deliver venom. Some of the bite is just a mechanical injury. Some actually has venom and they can be introduced to you through the bite or through what we call the venom ophthalmia, a spray of venom. Okay, not spit venom. Okay, they don't do that. Okay, they spray the venom, okay, through the fangs, and the target is our eyes. Okay, so the natural enemy for this so-called cobra, which are the spitting cobra, the name also wrong, spitting cobra, is to spray the venom in defense. Their natural enemy were wild dogs. So if you can imagine the snake head like this and the dog face like that, so the target is always to the face of the dog. The dog is always the head forward. So it can spray very precisely to target the eyes of these dogs, so that they cause pain and give time for the snake to escape. Not to eat the dogs, too big, but to escape and for defense. So that's why I said just now is for getting in, what you call getting their food, or to defend themselves. So for human, if it enters our eyes, we call it venom ophthalmia, and it's very painful and it can actually cause blindness as well. Okay, secondary injury. So regarding bites, as I said, it can be from with venom, without venom, or it can cause mechanical injury. So first, because it will penetrate the skin, okay, and it can actually introduce all kinds of bacteria into the wounds, and this can cause secondary infection. So what do we do in terms of first aid for such a thing? So we did a bit of a study regarding of first aid for snake bite in Malaysia. We look at about 3,112 cases. It's one of our paramedic degree study. So we did what we call a cross-sectional on pre-hospital intervention for snake-related injuries, consulted to REX from 2018 to 2020, just a 3 years for data. Sorry. So we find that the number of cases of snake bite is, for the consultation to REX, most of the cases were snake related. And we see that what we call the demography is between 40 to 59 young adults. I don't know whether you call 59 a young adult, but it's still an adult. Okay, it's age group. It's the largest group that got injured. And you can see the male number is much higher than the female for obvious reasons. Males are risk takers, so they go all kinds of unnecessary places. Nationality, Malaysian is more than non-Malaysian, okay? And regarding the ethnicity, Malays are the highest. Don't ask me why, they're just crazy group of people, maybe, yeah? Yeah, anyway, this is just an interesting data to look at. It's nothing really much, but we see from the consultation, the most of the consultation came from Sarawak. This is something that I think our KKM data before suggested Kedah and Perlis as the highest number of snake bite. Maybe true, but in terms of our REX consultation, mostly comes from state of Sarawak, followed by Pahang. Okay, so as you notice, these two countries are very big. These two countries, sorry, these two states are very big and very close to nature as well, very rich in natural resources, and therefore maybe the risk of getting bitten is also high. Okay, so Pahang and Sarawak, and then followed by Perak. So a lot of cases being consulted to us also from the state of Perak. Geographical area, basically most of the bite, if you notice, is in the urban area. That's very interesting, isn't it? You think that we come to snakes, it's all in the forest, in the jungle, in the kebun-kebun. Yes, it's true. But these are urbanized area around the house sometimes, okay, quite a lot. Not just around the house, but in the house, in the kitchen, in the bedroom, in the living room, people get bitten. That's very unusual. Huh? We think that we are safe in our own home, but it's not necessarily so. But it's due to our own action as well. We are calling the snake to come into our house actually by providing them the source, the food source. So they follow snakes are actually they will follow food source. Okay. So what is the food of snakes? Anybody? Is the ticos, okay, is the kata, is the chicha. So these are all food for them. So how do we create food for them? We actually throw food outside, not taking care of cleanliness, not taking care of what we call, how to dispose our waste well. So we are inviting the food for this animal, the snakes, which is snake, mouse, and so on. So yeah. So the way to reduce this is by being more careful with how we throw away our waste, okay, and keep cleanliness around the house, of course. So the other thing is that, sorry, it is the injury are mainly the incident also occur mainly outdoors. Okay, indoors they're still big, but mainly it's outdoors. And what about the snake species? We find that unidentified species is the biggest group incident, number of frequencies. Uh, more than half of them are actually unidentified snake species, meaning that somebody didn't see what bit them, or somebody just did not bring the snake that bite them after they kill them, okay, of course, or did not take any picture of the snake that bit them or caused the injury. Therefore it cannot be identified. So therefore in Malaysia we use a very strict diagnostic uh, algorithm, that we say if there is no evidence of the animal itself or no picture of of this animal itself, we cannot identify the species. And in Malaysia, we identify or make the diagnosis to the species level. Okay, so very precise. So if it is down to the species level that we can identify, we can classify either whether it is a venomous snake or is a non-venomous snake. Okay, that's very interesting. So you can see here the non-venomous snake is higher in terms of the number of bite that it can cause, and that cause the injury. Okay, so identified snake is also high. We've identified quite a lot, and all venom ophthalmia cases are actually caused by Naja sumatrana. So whether somebody see it or not see it, or have take a picture of it or kill it or not, if it is a venom ophthalmia, it's always caused by Naja sumatrana. Naja sumatrana. That's the only cobra that can cause a what you call a spraying venom to the eye. Okay, so we also identify that the activities mostly are due to walking. So don't go walking. I know Penang people like to go walking, hiking, okay, Bandera and so on. No, this is actually walking around the house. Okay, they walk at night, not looking at where they're going, did not see what's in the surroundings. Some go into the bushes, some go walking at the what you call kebun, all right, and they did not wear protective shoes and so on. They get bitten. Some of them walk around barefooted. Some of them actually wear just slippers. Right, being Malaysian, we like our sandals, our slippers. So they get bitten because they are this part of the anatomy is exposed. Okay, very very rare we find people wearing shoes or boots get bitten and cause injury to the foot. Okay, so simple shoe is actually helpful as well, or wearing long pants, long leg, what do you call trousers, that can also help reduce the risk of getting bitten. So in terms of the intervention, we can see here most of the people who got bitten did something. Okay, that's very interesting. The question is whether what they did is correct or not, right? So this is the problem. Most of the things that we find people do to themselves are inappropriate. Well, so what are they? So most of them actually apply tourniquet. That's the thing. Most of patients, I don't know why, for so long, they've been tying themselves up. Okay, after they got bitten, they will tie and put a very tight constricting band or kain or rubber tire and so on. Some even put wire, and that is even worse because it cuts the skin and cause injury further. Okay, so tourniquet is the most frequent so-called intervention that's done before a patient arrives to hospital, and it's very difficult for us to reverse this. We've been trying so hard over the years through public education, through media, and so on. Do not tie yourself. We even come up with a poster and so on that we can actually try to educate the public, but still happen. First reaction, tie. Okay, this may be from what we see in the movies and so on growing up. Those things doesn't help as well. Okay, so another thing that we find interesting in Malaysia is rather than just doing things inappropriate to themselves, they also did something to the snake. Funny, right? You think if someone got bitten, they will just run away. No, they will actually kill the snake and hunt the snake, thinking that if they do something to the snake, it will actually reverse the problem or the venom. They will not get envenomation, or the snake family will not go after them after they are kill the snake. Okay, so most of the time actually leave the snake alone, but some actually kill the snake, and then what they did was either leave it on the side, or what important things to see here, they cut the brain of the snake and apply it to the wound. They, some eat the snake, some burn the snake, some cut the tail of the snake and eat just the tail of the snake, thinking it is an antidote. So it's relevant for today's topic. An antidote is actually the tail end of a snake. Okay, so this is very, very, very interesting. If we didn't do the study, we wouldn't know. But from the consultation to Rex, we get all these details. Okay, and we can actually try to extrapolate this on how our society's thoughts or thinking is. Even after 21st century, these things are still happening. So if we want to make an education program, then maybe we should address, we know what to address. Okay. Okay, so this is the thing that we see with uh, stressing on appropriate safety-seeking behavior and appropriate health-seeking behavior is basically where gear inform others where to go, look at the safe surrounding environment, staying alert all the time when you are walking, for example. Emergency services know what to call, how to call emergency service, and of course, increase awareness and education. So for the health-seeking behavior is basically we need the public to move away from danger, do not go to the danger more and maybe cause more harm to themselves rather than just one bite. Now you get 2, 3 bites, or one person get bitten. Now you have 2, 3 people, others also get bitten just because they want to kill the snake, okay, or catch the snake. How to call for help, who to call, need to calm down. This is very important. If you don't calm down, you will not be able to think straight. Okay, so we ask the public, we cannot ask the public, do not panic. How do you stop people from panicking? People will panic. But we can ask the people to calm down. Take breathe in, breathe out, sit down, calm down. All right. So then what to do next? Remove all jewelries that is actually maybe in the affected limbs. Okay. Cincin and so on. We see quite a lot of people come to hospital, tangan dah bengkak, cincin still there. How are we going to remove? And dia kata, oh tak nak, jangan potong because this is sentimental value from my first husband. Oh, tahu lah. Macam mana kan? But it's basically, this is all about safety. So nak tak nak kita terpaksa remove lah juga. Okay. And then reduce movement. When we reduce movement, we will actually reduce the spread of the venom. Okay, so important to understand The venom is injected into our third space, into our tissues, and how tissue drains from the site is through lymphatic system. So lymphatic system is a low pressure system which is actually pumped by movement of our muscle. So if we reduce movement of the affected area, we will actually reduce the rate of spread of the venom from the bite site to our heart. And if it reaches our heart, then it will spread faster because it will go systemic. Okay. Right. So the main idea is to minimize movement. How we do it is either by splints or by calling others to carry us to the department of the emergency department. Okay. So this is what we come up with for our public do's and don'ts. Some of them are actually in our book already. You can have it. I've shared the link to our organizer. You can have the link later. So these are the things that we require our public to do. Very simple: calm down, reduce movement, and immobilize, then get to the hospital as soon as possible. Okay. Question is, should we go to only government hospital? The answer is no. Get uh, to the safety of the medical care. But the issue is sometimes people maybe not don't understand is our private hospital may not have stock antivenom. Okay, currently in Malaysia, most of the antivenom are stocked in the government hospitals. So eventually, once the patient is basically stabilized, they will be sent out or referred to the government hospitals or university hospitals. Okay, right. So the main culprit is basically for another injury I said just now for venom ophthalmia is a snake, cobra. We have two different species of cobra in Malaysia. This is one, which is Naja sumatrana. It can spray venom. Uh, on top of it can bite and deliver venom as well. So if you want to kill a mouse, it will bite. But if you want you to go away, okay, it will spray the venom to your eyes. So this is actually venom ophthalmia. If somebody got bitten, this is our bomba, our abang bomba. Abang bomba kita tried to rescue a snake, and when he was holding it, he forgot to wear the goggles. So he got sprayed and it entered his eyes. You can see both sides are actually very red, can be quite swollen as well. Okay. Luckily, they irrigate the eye on site. And when they arrive to our emergency department, we continue irrigating the eye and therefore diluting the venom and minimize the risk of corneal ulceration. And luckily, he did not rub the eye. Okay, if you rub the eye, then it can cause secondary injury, which is corneal, what do you call, scarring. Okay, okay. So this is what we have come up with over, I think, since 2010. WHO come up with a guideline on management of snake bite, but we found that this is too general for Malaysian use. Some of it is not relevant for Malaysia, so we come up with our own clinical management guidelines. Here an example, our friend in Vietnam got bitten by this snake. So since the doctor said you need to bring the snake for identification, he came to the hospital after bitten with the snake itself still in his hand, arrived to emergency department on the trolley. So what snake do you think this is? This is a real case. It's a big snake, blackish in color, well, the Vietnam version. So this is actually somebody got bitten by a king cobra. You can see the picture of the king cobra here. This is the king cobra. So this is what he did. He got bitten. He got bring the whole snake. He could have just put it into a bag or something, but the snake was still alive when he arrived to the hospital. So who wants to approach this? You want to approach this patient? You think? If you ask me, I will run away. Okay, who do you call? Call a bomba lah, huh? To rescue the snake first, to make the scene safe. Okay, so this is obviously not a good idea. Okay, we do say if you can bring the snake if it's killed, but if it's not, just take a picture. You can actually identify the snake. So in Malaysia, what can we improve today? First is optimizing medical care. Our training, one of the reasons why we have this also to improve the knowledge base of our pharmacists. The importance of stocking antivenom. Which antivenom should you stock? How much should you stock? When should you give? Okay, so these are all the things that we have to actually ask today and maybe answer later. So we need to be aware that we have an updated national guidelines. Oh, sorry, we have a national guideline for Malaysia. We published it in 2017, but that was 2017. There are a lot of things happened since then, and there are many improvement that need to be updated into this guideline. So we need to update our national guideline. Okay, and it's due already. It's more than 5 years. And we also have what we call a Wildlife and Dangerous Animal Act in terms of protection, which snake actually are protected not to be killed. Okay, and then we need to also emphasize on the clinical aspect of diagnosis, proper diagnosis. Okay, appropriate documentation is very important, and we have to continuously monitor the patient in what we call close serial observation and progression of the envenomation or bite. Some patient may progress to worse, some patient may not progress, some patient may actually progress to better. So how do you do this? We have to monitor it closely, and therefore patient will require, for example, continuous monitoring with the vital signs monitoring, hourly monitoring of the rate of progression of the edema or swelling, pain score. Those are all parameters that we can monitor closely to see whether our treatment, our management is appropriate, or if someone requires antivenom. So we don't give antivenom for all snake bite. Okay, that's very important to think to have in mind. We do not simply give antivenom for venomous snake bite. Okay, or not venomous snake bite, a bite by a venomous snake. Okay, even then, if someone got bitten by a venomous snake, as I said earlier, it doesn't mean that they will actually progress into systemic envenomation. Therefore, there was no reason why we have to give antivenom, and that's why close serial observation for progression is important. I still remember when I was a resident, everybody gets antivenom because the doctor was on call, doesn't want to get up. So just give antivenom for the sake of snake bite, not the indication of why one needs to get antivenom. So what I'm trying to say here, okay, this is what we do. We actually try to get this what we call appropriate diagnosis for the patient. Okay, if a snake is not brought or no picture of snake, then it is unidentified snake bite. Therefore, it's more and more important for us to observe this patient closely. Someone who brought a snake and then is identified as specimen, a picture, for example, we can actually say, oh, this is a non-venomous snake. Therefore, we can discharge the patient without actually admitting the patient, the need for admission, or the need for even taking blood sample from the patient or putting IV line. So that saves cost, save patient from getting more pain, right? So that's why we need specialization in actually managing snake bite, and therefore Rex comes into play. We are the one who actually trying to help both patient and doctors managing the case optimally. So you can ask Rex if you have any issue with identifying the snake, okay, or when to give antivenom, for example. Even though we have the guidelines, sometimes it's not clear, not confident. So we give the confidence in someone making the decision. All right, so this is another thing that we do. We actually monitor all this thing very closely. This is our blood test, which we do if somebody got bitten by a snake every 6 hours. Okay, every 6 hours, and we look at the trends. Okay, is it actually worsening, improving, or not? Okay, so we find that these blood parameters, what blood cell count, hemoglobin level, platelet, PT, this is coagulation profile, and also CK, are the blood tests that is relevant for the snake species injuries for Malaysia. It may not be for other countries, but for Malaysia, these are we find the most appropriate ones. There are other blood tests that we can do, but we do that on case per case basis or need per need basis. Okay. For example, fibrinogen level, for example, D-dimer, liver function test, renal function test. Okay, so those things are need by need basis. Okay, including also ECG, right? Some cases for cobra bite can cause cardiotoxicity and cause arrhythmia and also asystole. So here you can see example, the coagulation profile is prolonged, okay, not able to read, but after giving antivenom here, it improved back to normal. It's very, very interesting to note the progress can be very dramatic, can be, because our observation is every 6 hours, so we can see the improvement of intervention or the progression before an intervention as well. Okay, you can see here the INR is increasing. Here suddenly unable to read. So means that off the chart, right? Everything is off the chart. But after giving antivenom 6 hours later, after giving antivenom completion, things back to normal and remain normal until the end. So there's no need for a second dose, for example. This is an example of a case that we have. So another thing that we are concerned about is sometimes this patient get injury to the wound. So will antivenom actually help reduce the effect on the wound? So we find that even after giving antivenom early, here we can see the wound still progress. Okay, the wound still becomes quite bad eventually. So there was a need for antivenom. There's a possible role for local envenomation of the cytotoxic effect, but may not fully what we call effective in stopping the cytotoxic effect of asthmatic error. So this is a pathognomonic feature of a bite from a cobra. So as I said just now, we have two species of cobra. Both species can cause this feature, what we call dermonecrosis. Okay, dermonecrosis, lysis or tissue lysis from the venom effect, direct venom effect. So this is a local effect. So we measure the CK level. We find the CK is going up, going up, going up, going up. After giving antivenom, it starts to and go down. So it means that the what you call the size of the expansion of the necrosis stopped. These wounds also can cause what you call blister. You can see here blistering. So this may or may not be involving the venom itself, or it can actually also worsen by a secondary infection. And we find that these bite wounds sometimes is a very good media for growing certain organisms from the mouth of the snake. The commonest organism that we culture is from Morganella morganii. Okay, there are others, of course, but these are the most common organism. This is the most common organism, Morganella morganii. So we need to also consider doing culture and sensitivity for all kinds of snake bite, which has this type of injury. So we can tailor our antivenom according to the need of the organism itself. Many times we give antibiotics. We give augmentin. So we find that most of these Morganella morganii are not sensitive to augmentin. They are resistant. So most of them are actually more for third generation cephalosporin. Okay, they are more sensitive for that. So yes, okay. So wound care as well. If somebody, as you can see here, just progress after antivenom to quite big area of injury. So you can see somebody got bitten by a cobra here, dermonecrosis. What you see on top is sometimes misleading. It's actually quite very big area of necrosis underneath the skin. So when we do a debridement, when we call our surgeons, our orthopedic colleagues, it's basically meant for what we call the surgical intervention is for um, debridement, not for fasciotomy. Okay, for debridement, removal of the dead tissue, and then try to make sure no secondary infection, and if possible, for example, in this case, we do skin grafting. And this is between this first injury from the bite until this intervention is about, I think it takes about 3 to 4 weeks. Okay, when we make sure there's good granulation tissue, and then we apply the graft, skin graft, and this is 1 month later. You can see the progression is actually the patient accepted well and healing well with the skin grafting. So this is actual case of bite in HUKM, and we published the case as well. Okay, so another thing that we need to improve is adoption of technology. So as I mentioned just now, we can monitor things, but we can now use ultrasound to further precisely monitor the progression, to see where the injury are in the local tissue. Is it inside the fascia or above the fascia? So and those things are all actually able to help us. Is there any collection of pus and so on? So ultrasound is actually in the in thing now, especially in the emergency department. Because before we actually use a very crude method of measuring the pressure inside the compartment to see whether it has compartment syndrome or not. But with antivenom, this actually never happened. Plus, the injury itself through ultrasound, we noted that it never go into the compartment. It's just outside in the tissue. It's swelling. It's something similar to cellulitis. And we do not do fasciotomy for cellulitis, no matter how big the swelling is, right? So that's the idea that we put forward to our ortho colleagues, and therefore nowadays in Malaysia, very, very rare that we find patient with snake bite get fasciotomy. Okay, so no fasciotomy is actually needed if we give appropriate antivenom in the right amount, in the dose that we recommend for this patient. Okay, so this is very important. As you can see, how a medical treatment can help prevent or avoid iatrogenic unnecessary intervention. Okay. So this is what we do. We publish also ultrasound, our paper, and this is our work with our Taiwan colleagues. Okay, so we have now developed what we call the POLE protocol, POLE, POLE protocol. Okay, I will share this video later.
Pulse Protocol 应用焦点是照护超音波于龟壳花咬伤造成的局部组织伤害
Can you hear
治
it?
疗与评估。设想构思与实际执行的三军总医院急诊医学部人员。龟壳花是台湾毒蛇咬伤最常见的蛇种之一，生活区域分布全台。临床表现以局部组织伤害为主，其中肿胀、疼痛及发干最常见，尤其是患肢持续的肿胀最令临床医师困扰。换言之，最困扰临床的问题是，此时是否产生了急性腔室症候群，血清需要施打到什么时候才足够？我们提出 Pulse Protocol 来处理这些临床问题，包含3个步骤：一 Localization 定位，透过超音波了解肿胀组织所在的区域；二 RPP 计算肿胀进展的速率 Rate of Proximal Progression， 并依此数值的变化决定是否继续施打抗蛇毒血清。3 Draft 量测患肢受压迫的动脉都普勒波形变化，观察是否出现 Diastolic Retrograde Arterial Flow， 评估是否有发生急性腔室症候群。步骤1 Localization 使用线性探头定位肿胀的位置，寻找 cobblestone sign， 如左图箭头所示。有别于传统目测，超音波可以评估肿胀区域是在筋膜内或筋膜外。组织间水肿若发生在筋膜外，则发生急性腔室症候群的机会较低。步骤2，计算肿胀进展的速率 Rate of Proximal Progression， 找到 cobblestone sign 与正常组织的边界，并在皮肤上做记号。 固定时间间隔，依此药领标记，直到肿胀停止蔓延。将两标记的距离除以时间，可以得到肿胀速率，也就是 RPP。计算 RPP 并记录下来，透过记录可以发现，尽管肿胀仍在持续，但肿胀的速率会在某个时间点下降。我们建议，当观测到肿胀速率下降，即可停止施打抗蛇毒血清。步骤3：量测患肢受压迫的动脉都普勒波形变化，选取肿胀区域的动脉，比如足背动脉、桡动脉或肱动脉。找到动脉纵剖方向后，调整为都普勒模式，再使用超音波 （Pulse Wave Mode） 测量收缩期与舒张期波形。大部分健康成人波形都朝上，若出现反转朝下，表示此时组织压力可能已经略近于血管舒张压力，有可能发生急性腔室症候群。再次总结 Pulse Protocol 的3个步骤：1. Localization 定位，透过超音波了解肿胀组织所在的区域。2. RPP 计算肿胀进展的速率，并依照此数值的变化决定是否继续追加施打抗蛇毒血清。3. Draft 量测患肢受压迫的动脉都普勒波形变化，评估是否有发生急性腔室症候群。特别感谢台北荣总邓昭芳主任、台中。
Okay, so let's move on. So this is a technology that we apply. So now let's talk a bit about antivenom. Antivenom is, as you know, is the only treatment for venomous snake bites or bites from venomous snakes if it goes into systemic envenomation. Okay, as we see just now, local envenomation not so much that we can do so far, but if you give early, it can actually stop the spread. But what the main important thing about antivenom is regarding the systemic envenomation. And we have both for snakes in the land, which is cobra or the elapid group, okay, the crates. And also we have snakes in the sea, which is the sea snake. They also cause envenomation. And we have antivenom for sea snake envenoming. But the more concerning issue is that we do not manufacture this antivenom. So in Malaysia, we import it from either Thailand for the land snakes and from Australia for the sea snake. So we are actually at the receiving end of the antivenom. So if something happened in Thailand that the manufacturing is affected, it will actually affect our supply as well. So this is something that maybe we need to consider thinking in the future because the supply of antivenom is limited. So therefore, we need to see whether our need in the next 5 to 10 years is going to increase or reduce. And actually, with the WHO campaign now, we are targeting to reduce the snake bite. As I said just now, snake bite is a preventive disease. So if we can increase prevention, therefore the rate of bite is reduced. Therefore, indirectly, will also cause the rate of envenoming to reduce, and therefore the need for antivenom to reduce. So if we increase the knowledge and awareness, we will actually reduce the need for antivenom. Okay, so therefore in Malaysia so far, thank God, the producer of antivenom for land snakes is Thailand, are actually following the same kind of trend, and we are following the trend with Thailand. Our number of so-called need for antivenom is reducing, and that because of maybe reduced number of injuries. But we don't know how long this will take because other parts of ASEAN are also now looking at importing antivenom from Thailand. So the demand may be increasing from other countries. For example, in Singapore, in Indonesia, for example, in nearby countries like say, Laos, Vietnam, and Cambodia. Okay, these are all kind of sharing the same kind of pool of species that Thai manufacturers produce the antivenom for. So yeah, so we may find some competition in the near future when we want to stop antivenom. So we come up with a system also now is to share our expired antivenom. So expired antivenom is very precious. Okay, so don't simply throw them away. Please keep them for at least another 6 months to 1 year, as if it's not expired. And from our preclinical tests, we find that this antivenom can still have very good efficacy for envenoming, all right, for reversing the envenoming effect. And we have done this, what we call a study for our humanitarian supply of expired antivenom to Laos. Remember, I told you earlier, Laos had problems with having antivenom to stock, partly because of price, but um, we had an issue last time. A supply of antivenom from Thailand had to be temporarily stopped because of some issue with horse flu. Okay, so they cannot produce antivenom, so the supply reduced. So luckily, Malaysia at that time we had already do some effort of collecting expired antivenom and give to REX. So through the REX initiative in ASEAN, we send this expired antivenom as part of humanitarian and also sharing of resources to Laos. And they were using it, and they find similar outcome to patients with envenomation from, especially from Malayan pit viper. Okay, so it shows that it can be used. Expired antivenom can be used if you don't have the unexpired one. Okay, of course, it's something to do with ethics as well. So patient will require their permission to use or not to use this antivenom. But if they do, we find that the effectiveness is the same, almost the same, and the risks of developing secondary reaction is also the same. There's no difference. Okay, that's based on our study, and we have published it as well. Okay, so we've done other studies as well with regards to antivenom in ASEAN. We find that there is, as I said just now, some shortages in certain countries, and also the need for sharing these antivenoms in the region. And we find that Thailand and Malaysia is one of the best countries regarding to access for antivenom, but not so much for the other 5 ASEAN countries in the study. They still need a lot more. And even though some of them actually produce antivenom, but still not enough and maybe not appropriate for some these other species as well. So this is what we publish, and these are the examples. As you can see, the antivenoms that we have actually in 2 components. One is either selectively specific for each species of the snake, here cobra, king cobra, Malayan krait, banded krait, Malayan pit viper, and the green pit viper. But the green pit viper is mainly used for all the other green pit vipers as well, except for one species. Okay, this is what I said just now. Some snakes, venomous snake, doesn't cause problems to humans, or very little problems to humans, that doesn't really need antivenom. And then the other 2 is what we call a neuropolyvalent and hematopolyvalent. These are polyspecific antivenom. But even though it's called polyspecific, you can see here, for example, the hematopolyvalent is made from 3 different species of snake. And these 3, actually, one of the snake species, the viper here, is not present in Malaysia. So we only use this polyvalent for 2 different species of snake. Okay, 2 different groups, Malayan pit viper and the green pit viper. And for states which does not have Malayan pit viper, for example, Sabah and Sarawak, then you only actually this hematopolyvalent is only for the green pit viper group. So why you need to store hematopolyvalent in Sabah and Sarawak? You don't have these 2 snake species, you only have green pit viper. So why not just stock green pit viper antivenom for Sabah and Sarawak? You don't need to buy hematopolyvalent for Sabah and Sarawak. So the concept of, in the past, the reason why we use hematopolyvalent or the polyvalent is because we don't know the species of snake, right? So therefore we give. But now we know the species of snake, which in Sabah and Sarawak doesn't have the other 2. So, why? So, so this is all after our years of discoveries regarding snake bite. So we can better inform our pharmacists what species of snakes are in each state, in each hospital, which species, which type of antivenom is actually more relevant for your hospital. Okay. And then, of course, similarly with the polyvalent for neuropolyvalent, this is actually 4 species. Okay, one is the monocle cobra, one the cobra, one is the king cobra, one crate, and 2 crates. So a combination of 4 species. It's not meant to use for other species of snakes that cause neurotoxicity. Okay, so there's no coral snake in there, even though it may cause neurotoxicity. Okay, so there's no antivenom so far for coral snakes. All right, so what about sea snake? Yes, that's also one of the other thing that we use. We import it from Australia, as I said, and it is slightly different because it's a liquid form. The one that you saw just now, these antivenoms are all in powder form. Okay, we need to know how to reconstitute, and then after that we need to know how to initiate, and then how to then continue giving through the infusion. So I believe this afternoon you will have a practical session. I think you will have a hands-on practice on how to give or prepare and give antivenom. Okay, so for neurotoxic envenomation manifestation, for example, this is somebody got bitten here on the arm, a lady, and unidentified snake bite. She doesn't know what snake it is, but from the bite, we know that this could be from a cobra, and you can see there's some changes, the swelling and also pain and also some discoloration, most likely dermal necrosis developing. And she developed within 25 minutes after the bite, she had dizziness, vomiting 3 times. So these are typical early sign of neurotoxicity. But most importantly, what we find is that she developed ptosis. So you can see in this video, we ask her to, to look up. So you can see mata kuju, right? She unable to lift up the eyelids. Okay, very limited. So she has some difficulty breathing as well. Okay, so this is actually, you cannot sustain it. Huh? Okay, so this one is after we gave her antivenom. So we gave her a cobra antivenom. Now boleh speak, you can see she can speak much better and so on. So this is actually the what you call the miracle of antivenom. Things can change in front of your eyes, and because of we identified with close serial monitoring just now, we gave the antivenom even without having to intubate the patient or ventilate the patient. So we stopped the paralysis from coming from going into paralysis. So ptosis is an early indication to give antivenom. Okay, neurotoxicity. And in Malaysia, of all the snake species that we have, people will die mostly because of neurotoxic, unable to breathe. Okay, not so much from or unable to breathe or causing a cardiac issue, but not from a bleeding issue. Okay, we had some issues. We had some cases of severe bleeding problems, but so far in Malaysia, none has died yet from the effects of hematotoxic envenomation. Okay, partly because of the REX consultation. We identify the appropriate antivenom and we give them early, as not early meaning that timely manner. Okay, when it's indicated, we give it. Okay, so snake related injuries, in summary, it's actually a neglected disease for so long until REX came along in the early 2000 and 2009, 2010. So we've changed a lot in Malaysia. We advise on the appropriate antivenom. All this while we have been doing wrong things, causing problems with patient, probably directly kill the patient as well. With our intervention. So we come up with the revise our guideline with the appropriate one. So now the whole country can actually refer to this guideline. As I said just now, this was in 2017. So we definitely have to revise this guideline again. It's about time to revise. Many things has been updated, including also the use of pulse protocol. Okay, so in Malaysia, these are the main culprit of venomous snake that can cause harm to humans. But as I said just now, there are two species of snake in here. This is the most common. It's the most common besides the cobra. We also have the Malayan pit viper, and we have the green pit viper here. We call the Tropidelemus. So you are in Penang. So this is the most famous snake in Penang. You go to the snake temple, you will find this species. Okay, the Tropidelemus regulari. In Sabah, Sarawak, in Borneo, you have the Tropidelemus subannulatus. Their genus is the same. And we find that both of these species, actually, the venom doesn't cause much harm to human. Doesn't cause someone to go into coagulopathy. So this is from the REST consultation database, and we publish about this species. Yeah, so we do not need antivenom for these two species. And actually, the antivenom for the green pit viper do not neutralize the venom from the regular pit viper or the Bornean leaf pit viper. Okay, so even though there are a lot of people got bitten by these snakes, they do not go into issue of coagulopathy or even neurotoxicity. Okay, unlike the Malayan pit viper here, which can cause quite significant injury or the what you call morbidity. Mortality, we were lucky so far, even up to the severe level of continuous bleeding in front of your eyes. But with the timely antivenom that we have stopped in these hospitals, the bleeding stops in front of your eyes. Okay, patient reverse back to normal and go home alive. Okay, without much issues. But the neurotoxicity, we still have issues with the cobras. They can cause, this is spitting cobra, an equatorial spitting cobra, Naja sumatrana, and this is the monocle cobra. You can see there. Another cobra that can cause death is from the king cobra, Ophiopagus hana. And so far, this year, we have one death already from king cobra. So that's our first recorded death in Malaysia so far. In Malaysia, as I said, we are targeting 0 deaths now. The WHO target to half of the incident and death worldwide by 2030. In Malaysia, we are not targeting half. We are already targeting 0 death for the country. Okay, from all our campaign and also use of the appropriate treatment as well. This is our mangrove pit viper that's also present in the coastline from Langkawi all the way down to Johor. Okay, but only on the west coast and not on the east coast. Okay, so this is very interesting as well, the distribution of the species. This thing is very feisty. It can cause quite a big problem as well when it get bitten. On the highlands and in the mainland, we have the Hagen's pit viper, which can cause quite a nasty coagulopathy as well, and quite persistent in terms of the recurrence. You give antivenom, it normalizes, and then after 24 to 30 hours, it will actually becomes systemic envenoming again. We give antivenom, it normalizes. After that, 1 or 2 days, it will go back up. So it is called recurrence of envenomation. It's also happened in Malaysia, especially with the Hagen pit viper, green pit viper. You can refer to this picture in the ebook that we will share later. So this is the ebook. This is the old second edition. We'll give you the first edition through the organizer. So in terms of what we have done in the public, as I said, important to increase the safety-seeking behavior. We had a lot of collaborations. We try to make it as simple as possible, but not simply. And we, the National Poison Center is our collaborator in Penang, USM. We also collaborate with other societies of toxinology. Because of our efforts in Malaysia, we able to generate interest to other countries as well. So Indonesia formed the Society of Toxinology back in 2018. and then Philippines. This is sorry. Oh, sorry. Trying to go back. How should I go back? Uh, okay, I think that's it. So anyway, we've inspired Toxinology Society in um, Thailand. Sorry, in Indonesia, and also um, in Philippines. Also, they form a Toxinology Society as well. So we are looking at in the near future of ASEAN Fellowship of Clinical Toxinology. So we hope to achieve this. I don't know, maybe in 2 years' time. Hopefully, we have a fellowship. Okay, so that's it. And please check also our MyBiz, Malaysian Biodiversity Information System, where we have all the species of snakes in there. Okay. All right, I think that's about it. Thank you. Please attend of our courses as well, and some of the online that you can look at for support is the ID ULA Malaysia. This is on Facebook, and a few other groups that we are actually in collaboration. This is the NGOs when we conduct our courses. Okay, so I think that's it for my talk. Can we open for discussion, question and answer? Thank you. Okay, can you see this guideline? So you can find this guideline very compact guideline in our Malaysian Society of Toxinology website in the info page. So this is just a quick run for the information that a doctor can look at when they have a case. So this is a step-by-step approach in terms of what to do and so on for the patient. So you can put the date, time, and so on. And this is a tick process of what are the things that they can document in terms of first aid, rapid clinical assessment as a resuscitation, the investigations that they probably can do to help monitor the patient and every 6 hours, and then the detailed clinical assessment on the wound and also in patient general condition in general, and also sorry, the beaten area. So the RPP, just now you heard how to do a rate of proximal progression, a measurement, and also particularly on the neurotoxic envenomation. So because we know this kills patient, so we emphasize on the neurotoxicity sign and symptoms. For example, just now you saw how we examine ptosis. If the doctor was not there and the nurses and so on are not aware, patient might just straight away go into apnea. Okay. And then species identification, we have certain instruction of how if somebody brought the snake to the hospital, how to take a picture and then consult to Rex. So every hospital, almost every hospital has access to Rex consultation. So you can ask your emergency physicians in the emergency department how to get you into this. So not just clinician, but also pharmacists. So we had a pharmacist in the groups. So when the case come, they can actually be alerted to the need of antivenom or not. So because through the discussion, they will actually then be prompted whether and what type of antivenom is required, when to start. They can already start preparing it in terms of standby, and also get if they don't have it, they can actually source it from other hospital. So that's another good thing I find over the years working with pharmacists. They have a very good network. So when we have lack of antivenom, for example, from one hospital, we can actually call another pharmacy from another hospital and they can be sent over. So in the past, people send patient over. Nowadays, we are transporting antivenom rather than people, which is, I think, much better and safer as well. Okay, so we started this very early on when we had very limited antivenom supply. Certain hospitals only have, and we shift the antivenom. We transport antivenom rather than we transport patient. Okay, good. I have to commend the pharmacists in Cameron Highland Hospital. Sultan Haja Kalsum Hospital in Cameron Highland, Tanah Rata. They were one of the first few which actually able to really apply the concept of the appropriate antivenom supplies and so on. So because Cameron Highland was the highest rate of snake bite in Pahang. So at the time, and they did not have the appropriate antivenom. So we started from scratch for them. And rather than transferring patient to Ipoh, all snakebite patient to Ipoh, they're able to manage the snakebite patient without transferring since 2014, middle of 2014. So 100% transfer to zero transfer for snakebite patient. That's really great. And transporting patient from Cameron Highlands to Ipoh is not easy. It's dangerous, going down this slope. So anyway, these are one of our few success story lah. Actually, not few, many success story in how antivenom, how snakebite management can be optimized. Okay, so this is the antivenom. As I said, you can look at this indication. Indication for antivenom is very important. It has systemic envenoming and local envenoming. So if we have this in our observation, then antivenom is indicated. So first thing that you need to do is first to identify the danger signs on arrival, and also every short interval while the patient is in the emergency department for the first 24 to 48 hours. So we don't discharge patient less than 24 hours, okay, for obvious reason. As I said just now, some of the signs and symptoms of systemic envenoming can present more than 24 hours, after 24 hours. Some even, in our experience in, for example, in Cameron Highlands, they already went back home after initial antivenom given or no antivenom given. And then when we follow up, and this is another issue, we need to follow up patient, acute snakebite patient within 24 to 48 hours after discharge. Okay, especially when they have received antivenom, or if the snake bite is a venomous snake bite, bite by venomous snake. Okay, so where case the patient already went home, came back to clinic in Cameron Highland, Tanah Rata, we found that she went into coagulopathy again. So she was discharged, follow up, back into the hospital, and given antivenom again. So this is what the recurrence of envenomation that we identified. Imagine if the patient was asked to come back in 1 week later. Patient could have bleed at home, you see. So this is where instruction or advice by REX to the doctors in the hospital can save life. Okay, we see a lot of junior doctors, for example, will simply write discharge TCA 1 week in the clinic. So what are you going to find in 1 week time? Patient already passed the need for antivenom earlier, or things can get worse within the first 24 hours after discharge, right? So what about the wound as well? That's another thing. Okay, so many young doctors are not aware about these issues. So the way their instruction for discharge is actually inappropriate for snake bite. Maybe for others, okay, you can follow 1 week, 2 weeks after discharge. But for snake bite, we know that these things can happen within the first 24 to 40 hours after. Okay. So antivenom administration, this is an instruction of how to give antivenom, preparation, reconstitution, dilution, and rate of administration. So you will have a hands-on, I think, this afternoon with our senior pharmacist. And how much antivenom to be given? Now, dose of antivenom is not typically, one dose is 1 vial. No, that is probably for sea snake antivenom. 1 dose is 1 vial. But for the land snakes, 1 dose is not 1 vial. Okay, a dose is can be either 3 vials for pit vipers, or 5 vials for the initial phase for local envenomation for snake, for neurotoxic snakes, or even 10 vials as a first dose, depending if it is a systemic envenomation. So these are the things that we need to observe. General observation of patient condition. We always ask how does the patient feel before antivenom, during antivenom administration, and after antivenom administration. So all this will let us know the importance of picking up what we call failure of therapy. Let's say we give the wrong antivenom to patient. Obviously, patient will not feel better. Okay, we expect after giving antivenom, patient must get better. But if patient do not get better, that reflects or imply that this is a failure of therapy. Okay, and therefore we need to question again: are we giving the right antivenom? One, if patient get better and then actually become worse after that, are we giving enough antivenom? So these are the questions that always play in our mind when antivenom is given. Okay, some patient may get one dose, some patient may be indicated for a second dose, and does the second dose require the same amount of venom of antivenom compared to the first one, or is it half? What we call as top-up dose. So those are all depends on the condition of patient. I give you an example. If we have patient bitten by king cobra, king cobra venom is it can enter the body in large amount, and a patient can actually succumb to it very fast, and it can be it will need a lot of antivenom, king cobra antivenom. So our study shows that we probably require about 30 vials, okay, 30 vials of king cobra antivenom for severe envenomation, depending on how much venom enter the body. Okay, so we don't know how much. We cannot ask the snake how much you give this man, how much you give Dr. Khaldun when you bite it. We don't have this ability to measure the quantitative amount of venom in the body. But we've always pegged this to the response or clinical response to the antivenom that we gave. So improvement, whether it partially or completely, and we have to give time as well, right? Do not panic. I cannot say calm down. Yeah, everybody will panic, but just calm down and maybe we can think about it better. Okay, so criteria for repeating again is also in the quick guideline. And this is the one that I want to tell everyone. The very dangerous issue is on the anaphylactic, where everybody is worried. Actually, it's the antivenom that we get from Thailand and Australia is rather safe. They are rather good manufacturer. They follow the strict protocol of production, therefore less impurities, and therefore the risk of allergic reaction or hypersensitivity reaction is low. And we do find it in terms of anaphylaxis is very low in Malaysia, okay, less than 10%. Okay, but this the reaction, the how should I say, minimal reaction and so on, the mild reaction is also quite high. Our study in Terengganu showed about, I think, 40 or 50%. But it's simple itchiness, that one can be easily treated. But in terms of severe anaphylactic reaction, is actually low. So these are the feature of this antivenom from the one that we import from Thailand and also Australia. Okay, so don't worry so much. Just if something happen like that, we withhold the antivenom, treat the reaction, and restart the antivenom again if it's not finished. Okay, because antivenom is the the only antidote for inflammation. You don't have other choices yet for this time around. You still use antivenom. Okay. Okay. So management of venom ophthalmia is from irrigation. So it give you some idea of how to manage these cases. And this one is a very old one. The admission, referral, inclusion, consultation. These are all old details. You can actually forget about it. Just look at your Rex consult for the country. We have Rex Penang, and Penang have two Rex group. One is on Penang Island, and the other one Rex on the Seberang Jaya, and so on, all the hospital. So we have two Rex groups in Penang. So please join if you are either on Penang Island or on Seberang Jaya. Since that is the flow of how we manage snakebite patient, confirm or alleged. So Rex will have to identify and make the appropriate diagnosis. And then if there is a snake for identification, we will identify them for you. And to look at the patient progress is actually very important. It's called syndromic approach. So what investigations are actually necessary and how frequent we should do it. Okay. And of course, I cannot stress more than just look for close serial observation. It's very paramount. It's paramount for all snakebite patients, okay, whether you identify or not. And then the need from this then require whether you have antivenom and you have enough antivenom or appropriate antivenom. That's another question. And of course, after that, we probably will suggest or recommend the admission either to intensive care, to medical care, or surgical care. Okay. So we often also follow up the patient until the patient is discharged or post-discharge follow-up as well. Okay, so this is another thing that I want to show here is how to stock antivenom here. Antivenom appropriate formulation and how to hold the sufficient amount of antivenom for your hospital. So the pharmacist needs to be aware how do we first stock the antivenom. How do you know that your hospital needs this type of antivenom? For example, Malayan pit viper. Do you need Malayan pit viper antivenom in Penang? Anybody? So which part of Penang will need Malayan pit viper antivenom? The island or the Seberang Jaya? So the Malayan pit viper antivenom. So how do you know? You have to look at database. You have to look at your incident of snake bite in your hospital. So far in Penang as a state, the Malayan pit viper is only found on the mainland. Okay, Seberang Jaya, apa lagi? Kepala Batas all those areas. They have Malayan pit viper, but not on the island itself. So far, we have not have a case of Malayan pit viper bite on the Penang Island, unless somebody brought it onto the island and got bitten by the pet snake. Okay, right. So this happened as well. Right, patient are bringing and snake which are not endemic on at their place. Okay, so they get bitten. We have even snake from abroad, from Africa, brought to Malaysia. Patient got bitten and died because we don't have the antivenom for those species, right? So how do you do it? You need to know the number here. As you can see, the average estimate of snake bite requiring antivenom from a particular species per month. So this have calculation is per species. Okay, now you have several types of antivenom, so you have to consider how many are actually relevant for your state or for your hospital. And then we have the recommended maximum dose. So as I said just now, first dose may not be the maximum dose. So you have to look at the average amount of antivenom, maybe the past year, how much you're actually using it per dose for per patient. Can be 5 doses, can be 1 dose, can be 2 doses. We normally put it as a 2 doses. Okay. For example, Cobra is 10 to 15 vials. For Pit Viper, maybe 3 to 6 vials. Okay. So safety factor means, let's say if you were to have a batch of antivenom, some may broke, fell down, so break. So we add on a bit of safety. So we always stock a slightly bit more than what calculated it to be for the year. Okay, and then the other issue that factor that can affect your antivenom stock is actually how fast can you get a replacement of the antivenom if it's finished or if it's used, right? So some places may take 3 months. Some places in the past, in Cameron Highland, for example, it took them 3 months to get stock. Plus, because of some of these antivenom were not in the list of the pharmacy punya drugs. So it has to be imported. Kena dapatkan tanda tangan DG to be imported masa tu, Green Viper. But now I think it's much better. It's easier. Our central pharmacist in KL has already note about it, and you can actually get quite a fast supply or resupply of antivenom that is used. But still, you need to know this is a factor that will affect, because once you use your stock antivenom, you are now left with a vacuum. You don't have the stock. If, for example, the second case comes, right? So you need to add this on so that you have a constant supply. And the good thing about it is you don't have to keep the whole lot of batch at one time. So you can have some antivenom is actually manufactured at a later date. So your expiry date for that stock is actually going to be longer. Every time you use, you get new stock and therefore new antivenom expiry date. So you have actually continuous so-called prolonging the 5-year period of so-called availability of antivenom in your system. Right? Faham? Okay, so this is why so when you want to use it, use the one which is the oldest first lah. The one nearing expired first compared to the one that you just obtained yesterday and manufactured yesterday. All right. So pharmacists need to be a bit alert and a bit intelligent about how to give away or not give away, how to provide the antivenom for use in your stock. Okay, so this is you can go through this. There's a quantity of antivenom as a holding dose in the beginning for your hospital, and this may need to be done annually, so that you know whether you are actually constantly about using the same amount every year, or is it now decreasing amount. So you can tailor-make your holding stock per year based on the need that you have, your trend over the next few years. Okay, so continuously doing this survey lah for the holding quantity for snake venom. So for example, in Cameron Highland, the number is actually reducing. So they don't have to spend much money to restock the basal called quantity of antivenom for the hospital. Okay. Okay. So I think that's all from me. Any questions so far? Okay. So everybody is welcome to join the Kahoot snakebite envenomation in Malaysia. Number 3, JY. Number 2, Rose. And the goes to Adli. Okay, thank you everyone. So I hope you enjoyed the session. Any questions? Any last questions? Any burning questions?
Anybody has any questions?
Before we break for lunch?
No.
Well, we are early. 12:42.
None at the moment, Dr. Khaldun.
Okay. Thank you.
Okay, thank you so much.
Enjoy the
for
rest
your talk.
of the workshop. Enjoy the workshop this afternoon. Goodbye.
Goodbye. Thank you. Everybody wave.
Bye. Wave.
Thank you.
I can see you too. Okay.
Okay, thank you, Dr. Khaldun.
Bye.